think I'm going to be doing a Professor Whitty moment and asking for next slides, please. So hopefully that will also work for everybody on the webinar at home as well. So it's such a privilege to follow Harriet, who has so long and so passionately stood for issues facing women, and I strongly personally identified with many of those issues you mentioned. So thank you for sharing that, Harriet. And thank you to Leigh for inviting me here to share our work with you all. Next slide, please. So we are a charity that works alongside people with an acquired brain injury, autism and learning or physical disabilities to help them live as independently as possible. And we provide this support in our brain injury assessment and rehabilitation centres, our care homes, in people's homes and in a school. And through the last 40 years, we've established and expanded our expertise to meet the needs of people with increasingly complex and challenging disabilities. And alongside our care services, we also seek to work with some of the most vulnerable whose needs may not necessarily being met by current provision or practice. And my team, the foundation, kind of work to develop projects and programs which look to amplify the voices of those who are often multiply disadvantaged and to consider and identify gaps in both policy and practice. So we work across our organisation, the Disabilities Trust, to pull together our expertise in research and influence and policy change to improve outcomes. And for the last 10 years, the foundation has been working within forensic settings to understand brain injury and offending and how we can best meet the needs of those with a brain injury in the criminal justice system. And one of those projects we started back in 2016, and it was the first study of its kind in the UK and the start of the work that I'm here to share with you today. We provided a specialist brain injury link worker service to support the identification and rehabilitation of female offenders whilst they were in prison with a history of brain injury. And we undertook this work at HMP Drake Hall, which is a prison in Staffordshire. And in this project, we really wanted to understand the specific needs and experiences of female offenders with a brain injury, who are some of the most vulnerable in the criminal justice system. I think there's broad acknowledgement that women's life course experiences mean that their pathways to and through prison are substantively different to men. Violence, trauma, and addiction often represent those life-shaping events in women's pathways to prison. And research has shown that there's a clear link between life trauma, offending, and poor health outcomes for women in prison. And this was certainly reflected in the histories of women with a brain injury that we worked with. Next slide, please. So what is a brain injury? An acquired brain injury defines any injury to the brain which has occurred following birth. And it includes traumatic brain injuries, such as those caused by trauma from road traffic accidents, falls or assaults, and non-traumatic brain injuries related to other medical conditions such as meningitis, stroke, substance use, oxygen deprivation resulting from cardiac arrest or other causes. And a brain injury can be life-changing and can have a wide range of effects for an individual, leaving them scared, confused, and frustrated. And the effects can vary from person to person, and can depend on the nature and the severity of the injury. Typically, a brain injury can impact movement and memory and concentration, behaviour, emotions, and many more. Many may even have to relearn basic functions like walking and talking and eating. And although many of these will improve over time, some challenges may be harder to overcome. A significant number of individuals with a brain injury have hidden disabilities. And these affect their memory, their judgment, behaviour, and other higher functions. And although these are less obvious, they can be as disabling as the more obvious issues that come from a brain injury, and often go undiagnosed and misattributed to other conditions or even personality traits. And we see this often with women in the criminal justice system. So these symptoms can include poor memory, lack of concentration, slowness to process information, emotional dysregulation, anxiety, depression, fatigue. And importantly, a brain injury can result in a lack of insight, where an individual may be unaware of their symptoms or the extent to which they're affected. Next slide, please. So just to talk you through some of our findings at HMP Drake Hall. Although our project was not specifically designed to estimate prevalence, we found that 64% of the women at HMP Drake Hall had a history of brain injury. This chimes with the findings of higher prevalence of brain injury in prisons in much previous research, and with the higher rates of brain injury that we saw in our research in HMP Leeds, a male prison, back in 2014. And distressingly, 62% of the women reported that they'd sustained their brain injury through domestic abuse. And it's important to recognise that the experiences that these women shared with us were histories of intense trauma and abuse. A third of the women reported sustaining their brain injury before their first offence, and the average age of brain injury reported was at 25. Our findings also indicated that domestic abuse appeared to have an added impact to the brain injury and mental health needs, resulting in a higher rate of mental health problems for those who had experienced domestic abuse and brain injury rather than just a brain injury alone. I think it's also worth noting that the women we worked with had not received any support for their injury in the community, nor at any point in their sentence or engagement with the criminal justice system until they met the Disabilities Trust link worker at HMP Drake Hall. Next slide, please. Domestic abuse is a critical public health issue affecting nearly 2 million people in the UK every year. And whilst men do also experience domestic violence at the hands of their partners, women are far more likely to be victims and men perpetrators. And women overwhelmingly experience coercive control within a context of fear, higher rates of repeated victimization, and are much more likely to be seriously injured or killed by a partner or an ex-partner. Our work at Drake Hall only worked with women, and due to the gendered nature of this issue, we have focused on the specific impact of women to date. And as evident within these quotes on my slides, the level of trauma experienced in the lives of women with a brain injury was devastating. These quotes were taken from women that we worked with in prison and were highlighted within the independent evaluation undertaken by the Royal Holloway University. And whilst these quotes are distressing to read, I think they importantly illustrate the extent of the adversity and severe violence victimisation for these women. The women that we worked with at Drake Hall who had sustained their injury through domestic violence described to us prolonged periods of intense violence that was often directed to their head whilst they were unconscious. Next slide, please. And this is backed up by much international research, which shows that survivors of abuse commonly suffer blows to the head and non-fatal strangulation, leaving lasting psychological and physical trauma with symptoms which are often unseen and unrecognised by services. So research from the Ohio State University in America found 81% of domestic abuse survivors had experienced a blow to the head perpetrated by a partner, and a similar number had experienced non-fatal strangulation. And Zeman et al. Looked at a sample of women and men, although women represented 95% of the sample, who had been referred to a brain injury clinic from either a women's or a family's refuge. And despite 88% reporting more than one brain injury, less than a quarter had seen a medical professional afterwards. Next slide, please. So as I said, we have 40 years of experience working with brain injury and 10 years working with brain injury in forensic settings. But we are really clear that we need to work with our colleagues and experts in the domestic abuse and complex needs sector, alongside colleagues in brain injury, parliamentarians and officials, and indeed survivors themselves, to identify the best way and space to support women who have a brain injury. and who have also experienced domestic abuse. We recognise that we need to build this collaborative ecosystem of stakeholders who engage regularly to benefit each organisation and government to keep apace with the changes required to meet this issue. Next slide, please. So we've convened a roundtable back in 2019, gathering experts, including academics and representatives from leading domestic abuse charities and the NHS. And we asked them to consider the needs of women who've experienced both domestic abuse and brain injury from where they sit within their organisations and their practical frontline experience. We wanted to test our findings that we'd found in HMP Drake Hall within the round table and encourage that deliberative debate so that we could test the soundness of this as an issue from their position. And what followed was a lively debate and recommendations that were the product of multiple minds and viewpoints. Next slide, please. So within the roundtable, attendees acknowledged that there are challenges in identifying the specific impacts of brain injury for those that are facing multiple disadvantages. This is in part because symptoms of brain injury can be similar in presentation to the impact of trauma, mental health issues, or substance use. And when we look at the impact of brain injuries, such as poor memory, lack of concentration, emotional dysregulation, problem sleeping, that's a list of things that services, domestic abuse services, will be putting down on their outcome measures from the vast majority of survivors already. As we know and recognise these as impacts of trauma and for them having lived through domestic abuse. However, amongst attendees, there was a general agreement that regardless of whether or not causality can be determined, those with a brain injury will need additional support and adjustments compared to those without. And therefore, it's still important to screen and account for brain injury within these services. The debate also highlighted the importance of a screening process, to which there is none consistently across the country currently, and that this screening process should be sensitive to the emotional well-being of women, alongside the importance of brain injury screening being conducted at an appropriate point within the assessment process. And as shared within the quotes earlier, many of the survivors will be describing intense trauma during the disclosure of brain injury histories. And therefore it's vital that professionals are adequately trained to offer the right support following the identification of a brain injury. The discussion also recognised the cognitive function and how well someone's brain is working directly impacts on how able they are to process trauma within their lives. So cognitive, psychological and behavioural symptoms could cause increased vulnerability to further abuse and victimisation. If we consider the use of personal safety planning within domestic abuse services, which are used often to try and keep survivors safe, they rely on the survivor to quickly recall the safety measures and options available to them at a time of intense threat and stress. Then for someone with a brain injury, that level of emotional regulation and calm action may be incredibly challenging. The approaches and interventions offered to women also may not be as effective if women have a brain injury. And therefore, all approaches should be reviewed and considered through a brain injury lens to maximise the success. And therefore, it's critical that within services that support survivors, there is a level of education and understanding around brain injury. Next slide, please. So following all of that work, we wanted to further consider brain injury for survivors in the community as much as in criminal justice settings. And the following research is a continuation of this work, seeking to understand the level of awareness in practitioners about the way in which brain injury can manifest itself in domestic abuse survivors. So in August last year, with support from Safe Lives, a UK-based domestic abuse charity, we launched an online domestic abuse practitioner survey to ascertain the level of understanding around brain injury and its impacts. So we had a total of 381 domestic abuse services, and respondents reported providing a range of services from independent domestic abuse advisors. Others worked in outreach, on helplines and refuges and services for children. And the majority of respondents were frontline support staff. The survey highlighted a knowledge gap, sorry, next slide please. The survey highlighted a knowledge gap around brain injury across the domestic abuse sector, perpetuated by a lack of training to services and practitioners. We believe that training and education in brain injury are imperative in order to equip practitioners with the tools necessary to ask the right questions, to understand the possible impacts, and to adapt their provision to meet survivors' needs. Next slide, please. Nearly 2/3 of respondents felt that they were mostly unprepared to identify the symptoms of brain injury, and the remainder felt somewhat unprepared. So these are respondents from domestic abuse services across the country. Next slide, please. International research indicates rates of traumatic brain injury amongst domestic abuse survivors of between 35 to 85%. However, almost half of the respondents, half of the practitioners that we spoke to, believe that fewer than 10% of the people that they support had a brain injury. Rates of traumatic brain injury amongst the general population are considered at approximately 12% in the UK, and therefore the respondents' perception of the prevalence of brain injury in survivors is lower than that which would be expected in the general population. Next slide, please. I know there's a lot of detail on this slide, so hopefully they'll be circulated for you all later, but many of the respondents report asking about common causes of brain injury, but fewer asked about the related impairments. Survivors are reporting causes and common mechanisms of brain injury alongside common symptoms of brain injury in large proportions, including hits to the head, face and neck, or being thrown against the wall. Next slide, please. Survivors are also reporting being pushed down the stairs, having their teeth knocked out, and loss of consciousness, all of which could indicate a potential brain injury. The results of this study show that there's an apparent disconnect between what domestic abuse practitioners believe the scale of the issue to be in comparison to the regularity of potential causes of injuries reported by survivors. And when asked about the gaps in service provision, practitioners clearly cited to us a lack of training, a lack of knowledge and awareness about brain injuries, and also a lack of clarity about the care pathway for a survivor with a brain injury. It shows to us there's a need for increased awareness of brain injury and specific training and support for domestic abuse practitioners to ensure a better understanding of the needs and difficulties a brain injury could present. This in turn could improve practitioner confidence on how to best support those struggling with impaired neurofunction and deficits due to a brain injury. Next slide, please. So through our policy and influencing work, we've secured agreement from the then Minister of Safeguarding, and she's no longer in post, unfortunately, but for 2 practical steps to better address the needs of domestic abuse survivors with a brain injury. The Minister put forward, and it is now in place, that from April 2021, all those entering prison will be screened for a brain injury sustained through violence within the initial 24-hour screen and the 7-day secondary health care screen. The Minister also put forward that with the implementation of the new domestic abuse protection orders, there could be the inclusion of a brain injury within the statutory guidance. So domestic abuse protection orders protect victims from all forms of abuse, including non-physical abuse and controlling or coercive behaviour. An order would impose both prohibitions and positive requirements on perpetrators. These could include prohibiting any form of contact with the victim and or requiring the perpetrator to attend behavioural change programmes. So where police are attending a call out to a domestic incident, there could be accompanied with or shortly after visited by a domestic violence and abuse advisor, who would then be able to offer and extend support to the victim while the police dealt with the perpetrator. And part of that support offered by the domestic violence advisor would be an ABI screen as appropriate and with the consent. And whilst the detail is critically important here, the practical steps put forward by the minister do represent a significant step for these survivors. And we are delighted that our research helped secure the inclusion of brain injury and violence in the induction assessment for all new prisoners. Next slide, please. So we want to work together to help change the conversation around brain injury for survivors of domestic abuse. Just as we've done for the last 10 years within forensic settings, we must shine a spotlight on the significant trauma that these women are experiencing and the added impact of brain injury. This will take nuance and appreciation of the specific experiences of survivors. This will take engagement and collaboration and co-production with women and survivors, those working in brain injury and the domestic abuse sector and beyond. From our research, though, we believe it is critical for us to understand more and make changes so that survivors with a brain injury can access the support they need. We need to ensure that their screening is sensitive and trauma-informed. We need to know more on the prevalence, impact, and causality. And we need training and awareness for professionals supporting survivors of domestic abuse. Our work on domestic abuse and brain injury has illustrated the trauma and vulnerability experienced by survivors, but we recognise that we are at the very beginning of this essential conversation with our colleagues across the sector to explore ways in which we can better support these survivors and encourage change at every level. We look forward to continuing to work together to highlight this critical issue and hopefully improve the lives of survivors with a brain injury across the country. Thank you.